All right. Well, good afternoon, at least on the East Coast, everyone. Looking forward to this conversation as we head into, I guess, our first ever COVID Memorial Day weekend. We have some great speakers. Obviously, Ms. Keys will always lead us off, and we're going to talk about elder care and COVID-19. I know we've received a lot of questions over the past 7 conversation about this, so we want to focus in on it. And with that, I'd like to turn it over to Ms. Keys.
As always, Brandon and the MQF family, it's great to join you today. I'm really extra excited about today's conversation, especially because I feel like on some level, all of us can relate to the topic at hand. We're talking today about elder care, elderly compassion as it pertains to persons who are older and living through this coronavirus, COVID-19 pandemic. And joining us today, we have 2 fantastic panelists. We have with us Dr. Amita Patel, who is a certified medical director and director of behavioral sciences at Wayne Healthcare, where she has a Joint Township Hospital in St. Mary's, Ohio. I do kind of want to tease her a little bit about some sports-related things maybe later on, but I won't get into that so much. Dr. Patel is also a diplomat of the American Board of Psychiatry and Neurology, and she is also board certified in geriatric psychiatry and clinical psychopharmacology. She's a leading clinician and educator across geriatric psychiatry and a member of numerous boards. And so essentially, she's just going to bring us a serious wealth of information to us today. She's received her training at the University of Bombay in India, and she also did her psychiatry training from the University of Cincinnati at Ohio. So welcome, Dr. Patel. We're really excited that you're joining us today. We also have with us Courtney Lang, who's a nationally renowned patient advocate who primarily focuses on grassroots mobilization. She is a founder and principal of Lang Co. and Partners, which is a public affairs firm that focuses predominantly on community impact, on equity and care, on health policy. And she's also the co-lead on an award-winning campaign on depression called Depression is Real. And formerly, before coming into her Lang Co. and Partners affairs firm, she served as U.S. Public Affairs Liaison for Eli Lilly and Company. And so, and she too sits on numerous boards, was recently named, especially to the Board of Directors for Mental Health America, and also previously served on the Board of Directors for the National Caucus and Center on Black Aging. So she is going to also bring that perspective of equity and elderly care. And we're really excited. Also, I should mention that she and I are grocery store run-in partners at any time during the pandemic. Whenever I've seen the friendly faces, it's been Courtney's. So I'm really excited for both of you coming today. Why don't we just go ahead and ground the conversation and just let us know. I've read a bit about your bios to the audience, but if you can just let us know what got you into this work to begin with, why geriatric care, and especially both of you are coming at it from an angle of psychiatry and mental health. Why? What in your road, your personal road, professional road brought you to this place?
Well, I was born and raised in India, and we really lived in joint families. So I lived with grandparents. I had a grandmother who had Lewy body dementia, and we cared for her. And that really got me into going into psychiatry and becoming a geriatric psychiatrist. And now I've been working as a geriatric psychiatrist, especially in long-term care space since 1991. Unfortunately, I even lost my father to the same illness, Lewy body dementia. So this is really near and dear to me.
And similarly, just from a personal story, I appreciate that, Dr. Patel, because I relate to your personal narrative. I was a caregiver for my grandparents prior to their transition and have been raised in an intergenerational household my entire life. And we continue to commune together as a family. And the one thing that I think that I personally learned was the importance of advocating for my loved ones through the healthcare system. And I feel very fortunate to have had a career that was grounded in advocacy. And this current pandemic has really exacerbated some of those conditions and really encouraged my passion to champion the inequities in care, as well as the implicit biases that we have witnessed in the media alike. So that was really my motivation of continuing to make sure that the least of those that are often forgotten in society, are heard, that we represent their interests, and the full cycle of life from birth to elder care must always be on the forefront of our healthcare orientation.
I really appreciate you both sharing such moving stories about your start, and my warmth and gratitude to you and to your families for really allowing you to bring those orientations into your talk with us today. Before we get started, and Courtney, I'm going to go with you for the first question. Dr. Patel, if you wouldn't mind just turning your mic up a little bit so that everyone can hear all the fantastic words that you're sharing with us today. Courtney, so if you wouldn't mind starting us off and just telling us, outside of staying in home, staying in sheltering in place, what are some considerations that seniors face, that clinicians, that home care providers, that family members should consider as they're addressing elder care at this time during COVID?
Absolutely. So one of the primary aspects of this disease contagion pandemic is that it's not just having to grapple with COVID-19, but all of the other factors that have been compromised by having to be isolated at home. And for seniors, the social determinants or the social influences of health are particularly significant. So lack of transportation access, housing constraints, economic constraints, and should I say, even more so exacerbated by the numbers of seniors that are in poverty, that we often don't hear those statistics, but I do think the poverty conversation is one that we should always remember, that as people age, oftentimes their income does not maintain. And we take for granted a lot of times that people don't have retirement accounts and full long-term planning. So these types of considerations I think are really important for clinicians to consider, because it does exacerbate the ability to be well. And so when we grapple with isolationism for seniors, loneliness, anxiety, and depression, when you are stuck at home and you don't have access to your daily routine, the simplicity of routine is something that we cannot underestimate, because that helps to normalize life. And so when life no longer becomes normal, that is when we start seeing exacerbated chronic diseases that seniors often are just managing on a day-to-day: diabetes, cardiovascular disease, depression. And now we see not only those chronic diseases, but overlaid with having to care for oneself amidst a pandemic without necessarily having the proper resources of personal protective equipment, and being able to self-soothe in that type of way, to go to the store and to have access to friends, adult day services, and programming. It's a particular constraint that can really plague further a crisis that's already impacting us moment by moment.
Yeah, so those 2 points that you made, especially about the economic constraints that this time really does pose on elders, from a clinical standpoint, need to be taken into consideration. That's a social determinant of health, one's economic standing and economic wellness, right? And so I truly appreciate you offering that. The other part that I hope our audience are taking away from, or is taking away from what you just mentioned, is very much grounded in empathy. I think at this point, all of us can truly attest to what it feels like to have a disruption in one's routine, and feeling constrained to the home. And that's a place where, if we haven't before put ourselves in the shoes of an elder who is maybe staying in a long-term care facility, or who is constrained to being at home, we all know what that feels like right now. And so I really hope that moving forward for the rest of this conversation, we can maintain ourselves in that sense of understanding what it means for persons who live like that day to day, not just temporary as a result of a pandemic, and how we can think about the role that we play in helping to brighten an elder's life and understand the care characteristics and also the connection to comorbidities and things like that. So thank you, Courtney, for leading us off in that. Dr. Patel, I wanted to talk to you a bit more. So you mentioned and you shared with us that you lost your father to dementia, and a lot of your work is really based on mental health of the geriatric population. I'm wondering if you can tell us specifically what's the impact of COVID on the mental health of elders, and especially those who are in long-term care facilities.
What we've really seen is for the past 2 months, the patients have been really isolated in their room because of COVID-19, and what we've really seen is a great impact on their mental health. As it is, the patients, have dementia, and what we have really seen is their way of orientation is by contact with their family and the caregivers. And because of COVID, the families have not been allowed to come in. And because their families have not been allowed to come in, what's happened is that unfortunately, there has been difficulty with orientation. And sometimes we do FaceTime videos and things like that, but because of their dementia, it's hard for them to recognize their loved ones through the FaceTime. Also, we see that sometimes window visits we do, but they're not allowed to open the windows, so it's hard. If the windows are in the courtyard, families are not allowed to come in the courtyard, or they are on the different floors, and there's no access to the windows, so that cannot be done. So we see that really it's affected, that where the patients are getting more confused, so they're getting more depressed because of the isolation. And patients were getting up to go to activities. They were going to activity rooms. Now they are not allowed to go to activities because they cannot go in any communal setting. So they're losing more function too. So the patients will say, like, there is no reason to get out of bed because they don't want to get up in their recliner. They don't want to get up in their wheelchair. So they're losing more physical functions too. Also, you have to understand that they see the caregivers in the mask, in the shields. So they don't recognize the caregiver. So there is more refusal of care because their orientation is through a facial recognition. So there is more refusal of care. Because of that, there is more behavioral problems that we see. They'll refuse the medication, they'll refuse ADL cares, they'll refuse to eat, they'll refuse to be fed. So we'll see that patients are more paranoid, and so really the mental health problems have totally escalated. So it's not only the depression, the anxiety, but we see psychosis, behavioral problems, agitation, aggression. So unfortunately, difficulty with compliance that has led to actually complications related to their medical illnesses. So it's been a really decline in their health. So I'll tell you that my visits have really increased because of the need for this. So
yeah. Let's bring, before I go to the next question, to your point, I just want to get a sense of from the audience, how many of you do have relatives in long-term care facilities? And we have a poll question that will pop up on the screen, and you can go ahead and answer that. Do you have a member of the family or a close friend who lives in a nursing home, long-term care facility, or someone who requires in-home care? You can go ahead and submit that, and we'll find out who in the audience that is. Okay. We'll give that a couple of seconds, and as we're waiting for those results to come through, I'll just share a personal story. My grandmother, my paternal grandmother, is in a long-term care facility, an independent living facility in Philadelphia, and which is where my family is originally from. And just last week, was it, for Mother's Day, or 2 weeks ago for Mother's Day, my father, who and another aunt, who are usually the ones to see her daily, went up to her window because, to your point, Dr. Patel, they have window visits. They can't go inside. Rapped on the window and had arranged for her to come to the window, my grandmother, and had other family members on Skype so that she could wave and say hello. It's certainly not the same, right? And we saw her care provider in the background with, full mask, full garb. And my grandmother is already, I would say, she's the creative type. She's already quite fragile in that way. She's an artist at heart. So all of this has certainly got to be impacting her in a way that maybe she doesn't even have words for. So, I hear you when you say that. So it looks as if, according to the polls, a little more than half of our audience members have family members can really feel and understand what the story that you're mentioning. And thank you all for answering. And even for those who don't have family, I imagine you might know someone who does have family who are either carried at home and such like that. So Dr. Patel, you were talking about ways that communication and touching base with family members and friends who are older has changed. And so I'm hoping that Courtney can help to expound on that a little bit and tell us about, important healthcare communications that target older adults in this pandemic crisis, and not necessarily just in terms of talking to them one-on-one, but how is it that with these constraints in communicating, how is it that we can look at creative, innovative ways to spread information about COVID or about wellness during this time to elders?
Mia, the communication challenges have been so numerous from the public health lens because the communications were changing day by day when the pandemic first hit. And not that the understanding has improved, we have become more socialized, I think, to at least understanding that we must do something. The challenge for seniors is with all these new terminologies, and for people in general, PPE, quarantine, shelter in place, stay at home orders. These are all sort of new terms, disease mitigation, suppression, flattening the curve. All of it can become very overwhelming, especially when it's integrated into the day-to-day life. And it's not really clear, do you wear the mask and the gloves? Are you allowed to wear the mask at home or in communion with your family members? Is that a recommendation? Is that something that we should be further advancing, particularly when you are in households where you have a family member who is going to work or going to the grocery store, potentially an asymptomatic carrier, and bringing that back into the dwelling place. So kind of having an orientation or normalizing what is the protocol that can best safeguard seniors, I think would be very important, and for advocacy organizations to really advance what that standard is in conjunction with public health, particularly as we start entering into this next phase of the return to normal. So as we continue to kind of phase gradually in state by state, my concern is that our seniors are going to be left behind because it won't be clear what's the safest opportunity for them to integrate with loved ones and also go out and resume normal routine activities. So within our household, we have taken the stance that we will continue to wear masks when coming in contact and try to, as much as possible, physically distance from the grandparents and from the elders, and trying to make sure that the kids are separate and apart as much as possible, and really being diligent about surface disinfecting, because there's still confusion there. Surface cleaning versus disinfecting, soap and water versus Lysol and Clorox. I mean, so we must have a standard of care that we can effectively communicate to help protect the lives of the elders.
So I want to go back to what you were saying in the beginning, Courtney. So you were talking about how all of this language has got to be confusing, certainly for the regular layperson who is maybe who is young adult to middle-aged adult. But for our elders, language like PPE, quarantine, sheltering in place, certainly confusing, especially the orders behind it, as you mentioned. I'm wondering if both of you could talk about a little bit more about those who are limited in English proficient and additional concerns that elders whose first language is not English, or who don't have high health literacy rates, what some concerns might be around that.
Well, there has been a epic failure around translating public health communications to multiple languages. So I really believe that we need to adopt a universal infographic model so that people understand what they need to do to best safeguard their own personal health. Some of the challenges that we've seen in long-term care facilities, and Dr. Patel would be more of the expert on this, but with the rates with Black and Latino patients, or residents rather, having 2 times the occurrence of disease prevalence. New York Times did a feature yesterday about long-term care nursing facilities having 2 times the prevalence, 20% of all cases of COVID-19 hitting Black and Latino residents in urban and rural areas. So we have a problem with communication as well as safeguarding inside of facilities. And suffice to say that if we did a better job universally of having some type of standard, and I really believe, to your point around limited English proficiency, we need to adopt the infographic that's posted up everywhere, that every single person knows this is how someone should approach me, and this is how I need to protect myself. And that should be our universal standard. It should be another version of American Sign Language that we have embraced so that we can make sure that all individuals are protected.
And we can use a lot of pictures, you know, and infograph, and I agree with you that translation has been very difficult, and we've seen sometimes when we have Asian residents and the language barrier, and Latino, the language barrier is really great. Sometimes, and these patients have also high comorbid other conditions that are not recognized, which puts them at much higher risk. You know, unfortunately, what we have really seen is the third of the COVID-19 deaths have been in long-term care. Though only about 12 to 15% of patients have been affected in long-term care, but the deaths have been, third deaths have been in long-term care, because these are the most vulnerable population. And it varies by state to state. Like in my state, in Ohio, 70% of deaths are all in long-term care. Unfortunately, the reporting is not really universal throughout all states, because it's not mandated in all the states how they do the reporting. Some states will report, and we have few states that don't report anything. And we have states that will report cases in workers and in patients, and there are states that will report cases and deaths. So it's not universal reporting, unfortunately.
So Dr. Patel, let's stick with that. On the federal level, from a policy standpoint, what needs to happen, or what has happened so far with the COVID-19 related packages to help quell a lot of the issues that long-term care facilities are facing? Or is there still a serious gap in terms of regulations, in terms of standard of care, as Courtney's mentioned, to really help to comprehensively formulate a national approach to caring for elders in facilities?
I think there are serious gaps as far as regulations in caring for elderly. There was, at least I go to various facilities, and all the care as far as caring for COVID-19 varies from facility to facility. There is no standardization. There needs to be federal guidelines as far as standardization for caring for elderly, as far as PPE, as far as who's allowed to come, how the visitors are screened, how the staff is screened. It really goes, there has to be some federal guidelines, there has to be state guidelines. Unfortunately, what's happening at the current level is it varies from corporation to corporation who owns the facility, and that's not good. And you know, at least in Ohio, we see that there is some mandated reporting regarding total cases, current cases for workers and everything. So we see the numbers growing because I monitor it, but that's not universal. And it's because we do not have this kind of standard. So, and this is a very vulnerable population because, you know, not everybody has a private room, and the workers move from room to room. So they become carriers then. And that's the unfortunate thing. And you have to see this is high-risk population because they are immunocompromised and they have a lot of respiratory illnesses.
So do the same issues apply for those who are sheltering in place, who are not in long-term care facilities? In terms of what you're mentioning, Dr. Patel, and all the things that we've mentioned so far, how does any of this change when the setting changes and you're at home?
It is similar in home too, because they have in-home caregivers that come in, and there is no standardization for in-home caregivers also. So there has to be some mandated guidelines for in-home caregivers also, and we do not have that yet.
Okay.
So that goes, so there has to be some federal guidelines that need to come for elder care, whether it is in long-term care or for in-home care or for adult daycares. So it needs to be really across guidelines.
Yeah.
Because CMS needs to have better guidelines. There are guidelines, but they are not up to par yet.
Mia, I was saying you had mentioned some of the policy consideration, and I know that the HEROES Act made it through the House last week, but is being considered in the Senate. And I really think that this is an opportunity for individuals to make some noise and raise some attention to the opportunity to yield some advocacy in support of expansion of the Older Americans Act and addressing some of these COVID-19 concerns for both patients, for elders, for frontline workers, and expansion of SNAP benefits, etc. Some of the considerations that we were talking about at the top of the hour, as well as what Dr. Patel just raised, because we need to have more voices engaged. The states are left oftentimes to determine the fate of seniors within their jurisdictions, and I think Dr. Patel highlighted the concerns with that, both with corporations and with states interpreting what that guidance should be. So hopefully we can generate some attention to the HEROES Act so that we can put some pressure on the Senate to make that a reality, to help to continue to protect older Americans.
Yeah, and you know, definitely encouraging those who are on the call to be in touch with your senators, especially right now, because as Courtney mentioned, the HEROES Act is being considered in the Senate. Optimistically, it would be great if everything that's currently included in the House version is passed. Realistically, you know, is a different story. But if there's some things, to your point, that can be maintained, especially with respect to SNAP, especially with respect to these essential needs of elders, then please make noise. Call your senators, call and ask to speak to their health liaisons, their health staffers, talk to them. Of course, we can't meet in person right now, but have virtual meetings with them, send letters, call. They're responsible for answering their phone. So we talked a little about what's happening on the federal level from what you just offered, Courtney, and you also talked about the Older Americans Act and extensions there. Maybe someone can put a link to the Older Americans Act in the all panelists chat. But otherwise, I'm wondering, Dr. Patel, if you can help people to also think about not just advocacy on the federal level, but what can also happen on the local and state levels, and how can people work with their local health departments to come up with more comprehensive regulations in long-term care facilities as well as for at-home care workers, and maybe even have joint state agreements around all of that. And both of you can chime in. I'd like to start with you, Dr. Patel.
And I think what the governors have done is, the governors have made like local, each governors to deal with COVID-19 have made a group of 5 governors got together to how to deal with COVID-19. And what they can do is, again, come up with the policies on how to deal at a 5-state level regarding, come up with the policies to cope with the long-term care and also elder care. And if we can really advocate to them directly on how to come up with the policies, because right now what's happening is when I go into the facilities, the directive changes from week to week on how they care for these people. And unfortunately, that's stressful for the staff too, because sometimes one week they are told to care for these patients like this, and the other week it changes. And it's very, very hard for them. Just imagine even the staff, when they are caring for this elderly, they are wearing those masks and those shields for 8 to 12 hours, and they have difficulty with hydrating themselves and eating. And, it's hard for them to deliver care with all the garb, that PPE that they are wearing for such long hours, So, and the workload has also increased for them because they are delivering everything to the patients in their room. And it's really, really hard on them. So really the policies, if the governors can get together like they have to deal with COVID, like 5 state governors have gotten together, if we can really advocate directly to the governor level is what needs to happen.
And for those who want additional information on what governors are doing, I can't recall the exact title of the document, but it's something like Governor's Emergency Response to COVID-19. You can Google it. I've read most of it. I'm still going through it, but you're right. There are a number of states that are coming together, and we need greater coordination, of course, across states. What we are seeing in terms of across state coordination has to do with telehealth and emergency preparedness around telehealth and delivery of care in that way. I'm wondering, Dr. Patel and Courtney, if both of you can talk to us a little bit about how delivery of care in terms of modalities might forever be changed as a result of COVID, or where we see some innovations, especially in the mental health space.
Well, I think that telepsychiatry and telehealth counseling services has really improved tremendously since the start of the pandemic, because some of the restrictions state by state, of course, have been lifted, allowing more providers to be able to care for patients. The FCC has done a great job, a little plug to Commissioner Starks for his work, making sure that the Lifeline program allows for internet access so that individuals can actually have a telehealth consult. I think that a lot of us take for granted that everybody is online, and that is definitely not the case. There are lots of Americans who are geographically isolated or simply do not have technology at their hands, or if they do have technology, there are also disparities there in terms of utilization. Have they been taught how to use it properly? And in the absence of having someone in the household with you, it can be even more challenging if someone's unable to walk you through how to actually engage in a telehealth visit. So I think there are broader considerations. I think we've done a good job at making sure from a mental health perspective that continuing to champion access to telehealth services is critically important. We don't want those restrictions lifted. My concern is that once we sort of have this, again, phased return to normal, that some of the opportunities that allow patients to engage with providers would then be compromised and would be taken away. So we want to make sure until we have really gotten a full control over this pandemic that we don't compromise access to care for patients. We want to make sure that from an advocacy perspective and just raising the noise to make sure that providers always have the opportunity to be able to deliver mental health services to the patients at home, in facility, anyone who is in need. Because if now, not then when, it's more critical now than ever.
I very much agree with you, Courtney, that we need to continue the ability to give telehealth care. And we've run into the same problems that you described. You know, a lot of people do not have access to sometimes internet accessible phone, because, you know, they have what we call the Obama phone, which do not have internet access. Or they don't, they don't have the ability to know how to use the telehealth technology, or that's the problems. Or in long-term care, I can tell you that I want to do telehealth visit, but the staff do not have the time to go to the patient, and the patients do not have the ability to do it themselves. So, and I do not have access to the patient's direct telephone line to be able to call, you know. So those are some of the limitations with telehealth, I can tell you that. But it's better than not having the visit at all. So I don't want it taken away. But I'll tell you that sometimes a telehealth visit is very limiting, because going in, I can talk to the staff regarding, and I can log into the chart, but it's very limiting to what I can get from the chart than directly talking to the staff. And patients are not going to tell me everything unless I'm right there to see the patient. And so telehealth visit is still very limiting, but it's better than not having the visit at all.
So there are definitely some pros with telehealth, and telepsychiatry has been a leader in pre-COVID for a very long time in terms of telehealth. But clearly there are some places where challenges still exist, and hopefully this opportunity in crisis will really help to extend and help to ground and address some of those challenges. Dr. Patel, so you've mentioned now twice the burden of care delivery in time of COVID on staff. And I'm wondering, and this is a question from the audience, if you can just speak a bit to the burnout rates and the impact on staff who are in long-term care facilities, but then also potentially those who are in home, who are home health aides. And then if we can also bring into this conversation workforce issues as it relates to an immigrant workforce and those who are coming in, and many of them do occupy service jobs amongst the elderly.
We've really seen, normally in long-term care, the turnover rate for nurses aide and nurses is very, very high. It's almost 20%. And in time of crisis like this, we've seen even higher. The call-in sick rate is higher. So unfortunately, the burden on people who actually show up to work is even higher. And the workload is higher now because you have to provide all the care in patient's room. So now you have to deliver all the food to them. You have to provide some individual activities to them. So activities have now changed. So activity is now helping them call and do FaceTime with their family, doing individual activities with them in the room, encouraging them to get up and doing individual play with them. So providing physical and occupational therapy in their room. So the workload has really increased, feeding each individual patient in their room. So the workload has really increased, and then wearing that PPE. Every time you go out, you have to come back in. Even if you go out for some fresh air, you have to come back in. You have to redo your PPE. You have to have your temperature taken. So it's really, really hard on them. And the burnout rate is very, very high. And I really, really commend the people who are working in this environment. My heart really goes out for them. So. And even the home health workers who are giving individual care, It's they're working long hours. They're working 12 and 18-hour shifts to give care to the home health people. So it's very, very hard on them.
Yeah, Mia,
So,
I was going to add on that, would just build off of what Dr. Patel said, that are honoring the frontline workers who are from immigrant backgrounds with a space and place of cultural humility, so that we're respectful of them, just like we are respectful and we advocate for being respectful of patients is equally as important, because it creates a better work environment and therefore better care for patients. So we want to have a symbiotic relationship. And I firmly believe that our care providers should be encouraged to have mental health screenings. Mental Health America has a great screening tool. You can just kind of take it, because they also need to be encouraged to talk about how they're feeling emotionally, carrying that burden. And sometimes they're forgotten. So I appreciate that question, because we oftentimes take for granted those who are caring for others. And they are truly a prized aspect of our healthcare system. And we need to make sure that their mental health is intact, just as the patients.
I absolutely agree. And so before we move on to another set of questions, I do want to ask the audience another poll question. So get ready to give us your answer here. Tell us, what's the number one need for elder care during this current pandemic? Is it food and essential supplies? Does it have to do with prescription assistance, with telehealth technology support, technological support, with social connections? And we've talked about all of this to some extent already. So go ahead and give us your thoughts on that. Okay. And as we wait for that to come in, I do want to play a bit with our imaginations. Hopefully, yes, all categories are needed, absolutely. But what's the number one? So hopefully, we will all live to long, ripe age, whatever we consider that ripe age to be. But we do know that in certain parts of the US, in certain cities, even these cities can be next door to one another. Life expectancy is completely different in one city for a certain demographic compared to the same demographic, or to a counterpart demographic in the same city or in different cities. So for instance, in the south side of Chicago, the life expectancy rate between Black men and white men is like 16, 17 years, right? Which is ridiculous. Most people are saying the number one need for elder care during COVID-19 pandemic is social connections. I also said social connectivity. Yeah, mostly because of the mental health connection there, and just the fact that we need each other, right? We absolutely need one another. And how can you be together while also apart, while honoring that? But anyhow, so thank you, audience, for answering the question. If you were to put yourself 20, 30 years from now, and maybe you will need assistance in some way, and what are some of the things that you would really want to see in place for you? And how can people today advocate so that 20, 30 years from now, we won't be having the same level of conversation? Because we will have another pandemic, we will have another public health crisis. What needs to be in place? What do we need to advocate for to be in place today so that we're not coming up against the same issues 20, 30 years from now?
Everybody needs to have a healthcare directive on file, ready to go. It's something that we don't like to talk about, particularly communities of color. We don't really like to deal in the realm of end of life planning, but just like we plan births in terms of what's going to happen when you go into the delivery room, we need to have the same level of attention and detail when we're exiting the life. And we want to be in charge of that. We want to be empowered with our end of life care. And so considerations around palliative medicine and what type of life-saving functions you want to be performed on you or not should be your determination now versus when there's a crisis. So one of the things that I hope, Mia, that comes out of this is that we can actually have the conversation, so that when it is 20 or 30 years down the line, if we're so fortunate that those decisions have been made, and we made them at a time when we were feeling good, we were healthy and strong, and we might have been inspired by the current pandemic to make those decisions. But that's a good thing to have control of our own destiny right now, today.
How then, Courtney, given what you just said, what are some tips that you have for people who might be a little reticent to talk about end of life, to talk about transition, to even say the word death? And of course, right now we're talking about COVID, where a lot of people are dying due to comorbidities that are exacerbated by the pandemic. But for natural progression and aging, ideally that, we would certainly want to be empowered. So what are some tips that you might have for people to work through that now?
Certainly. So one of the programs that I really like at Holy Cross Health, where I serve on the board there and chair their population health committee and mission, is we have a check-in program. So we have 2,000 seniors enrolled in our program, and we check in. So it's a friendly call. It's not a clinical call. It's not a clinical visit. It's a what do you need kind of call. How are you feeling kind of call. And that helps to have a relationship, a rapport, when someone's checking in with you on a regular basis. So I think we need to first adopt a check-in. And then once you have a check-in, whether it's with a hospital provider, whether it's with your primary care, whether it's with an organization that you feel good affiliation with, Meals on Wheels or the YMCA. If we adopt this sort of check-in opportunity, we can begin to introduce conversation around what would empower you the most going forward. In the event that something did happen, how do you want it to be handled? But I think you have to have trust and confidence on the front end. And Mia, you said it perfectly, empathy. You have to approach the entire conversation about relating this human connectiveness with empathy. And by building rapport and relationship through that check-in, we can then, second or third conversation, just begin to introduce the concept of, I want you to be the determiner of your destiny. So I think that that's one tool. I think that families and caregivers need to begin to have a less scary orientation around the dialogue. And as I suggested, we do a really good job at the beginning of life. We don't do as great of a job at the end of life. And I'm hoping that when we have access to dialogue and we have familiar resources, particularly with communities of color, Black and brown people need to hear from folks that they feel a confidence with, that they feel are genuinely invested and concerned in their well-being. That makes a huge difference in saying that, you know what, I don't mind entertaining the idea of giving thought to what may need to happen down the road. So I think check-in, community building helps to level set the playing field a bit. And that's what I would recommend.
Thank you for that. And I'll share a personal story before I ask just final questions, as we're coming to the last 10 minutes or so. So I have, two stories. One, my parents are getting older. They don't look it. They drink a lot of water and non-alcoholic beverages, right? So they look fantastic. They're active. They eat well. They're very engaged in their community and with family. But we do now have these conversations of, when it's my time to go, this is what this is my wish. This is how I want you and your siblings to set things up, and we listen. It's not an easy conversation to have, but we do know that, to your point, we will return to the earth from which we've come, right? And it's just inevitable. So we certainly want to be as prepared and empowered as possible. So I appreciate you offering that perspective of getting over any cultural related stigma, and first and foremost recognizing that there is stigma in a lot of American societies, especially around death and dying. There's a silence around it that's not empowering. And from a spiritual perspective, it is a liberating conversation to have, but still difficult in a lot of situations. And then with that said, I have lost a very, very, very close family member to unfortunately a disease that progressed quite quickly. She was young. She was in her 30s, and she had children. She had a husband, and the one thing that I'm completely grateful for her life and what I learned from living within her presence. One thing that I certainly learned is that it's okay to have these conversations of going.
Yeah.
And in the aftermath, there are still conversations to be had in terms of care of family who are still here, and working through all of that. And there's a mental health component. And for those of you who may be going through that right now, or who have gone through it in the past, and all of us will go through it in the future, there's a book that I found really helpful to read by Mitch Albom, and it's called The 5 People You'll Meet in Heaven, or something like that. There are actually 2 books that he wrote, and one has to do with watching a loved one of his die. The second one has to do with what do you do in the aftermath. So I certainly encourage all of you to read those books. Mitch Albom, Albom. Okay, so let's go back to some of the questions that come from our audience. We talked a little bit earlier about delivery, the changes in delivery of care in terms of mental health. I'm wondering, before patients become, especially dementia patients, start to reach points of no return, what are some ways that families can become prepared? Dr. Patel, you mentioned a little bit about your personal and professional experience, and so I'm wondering if you can help us through that and talk to us about ways that COVID might make a lot of that challenging.
With dementia patients, unfortunately, they are at a much higher risk, especially with isolation, because I see that compared to other patients, dementia patients have been more isolated in the room. More so because they cannot understand how to keep the PPE on. So they are not allowed to leave the room because they cannot keep the mask on. They will touch other people because they do not understand distancing. So I see that they are being more isolated in their room. So they are at much higher risk. And unfortunately, they are the ones who do not understand the FaceTime. They do not understand. They don't recognize their family when you are doing any Skype or anything. So their ability to communicate via technology is also very, very limited. So I see that they have more mental health problems because they have lost that connectivity with their family, because their families were spending much more time with them. And so I see more depression in them, more non-compliance, and more confusion and more agitation because they don't recognize even the staff giving care to them because of the staff wearing the PPE. So the way the families can cope with them is, I would say that if I've seen some families use this, and that really worked, that if they have videos actually made rather than just, so the videos are really powerful. So if the families actually made conversational videos, that really can stick with them. So videos have been really, really helpful. Sometimes even the picture poster, because they have picture memory. So picture posters by the windows have been really helpful. So those kind of things have been helpful with these patients that I have seen to be quite useful with these patients. But if they can really wear the PPE, and if they can come out with the gloves and PPE, then they're allowed to come out a little bit of their room. That will maintain some of their functions. So
I really like that idea of pulling on story and picture memory to help those who are carrying dementia and their family members to cope. Thank you for offering that. I wanted to talk a little bit more about the grieving cycle related to COVID for those who have passed on. Right now the physical distancing constraints make it so that people can't grieve in the ways that they might customarily be used to. And the funeral service being amongst those things that, that are constrained. And so I'm wondering if you can talk to us about ways that families can properly grieve, even if they're unable to come together in situations that are culturally most appropriate.
Go ahead.
No, I was just going to share. Just this morning, I was provided with a link to a funeral home that was doing a live sort of televised virtual service for a distant relative. And I thought, how nice that they're trying to be inclusive, at the level, at the funeral director level, to try to engage, knowing that they're just going to be the immediate family present, but this is an opportunity for other individuals to support me. I think going forward with that, I do believe that there is a spiritual component to that, and really making sure that we're staying connected with our places and centers of worship and our support systems that we find. Some people don't feel as supported by families. Some people feel more supported by places of worship or by friends. And I think that by being inclusive, setting up a community where you feel the greatest amount of support will in turn provide the greatest amount of benefit going forward. And we have found oftentimes that by channeling that advocacy, it's a way to honor the loved one, whether it's advocacy for Alzheimer's and dementia, brain diseases. You shared about the loss of your friend, being able to tell their story in some kind of way that honors the life that they live makes all the difference in the world, because that keeps their spirit and the energy of the person vitally alive. The body is gone, but they're very much present, and we honor them as such.
I really like that advocacy to channel the loved one. And in full transparency, it was my sister, my older sister, who passed. But definitely a friend still, still very much a friend. But thank you for that. You mentioned the role of faith-based of worship centers, and so I wanted to build that out a little bit, because you were both talking about social isolationism and things like that. What role should faith-based institutions, especially now, play with respect to social isolation that all of us are experiencing, but especially because worship centers are especially strongholds for elders.
They are, and they're part of the routine that so many seniors feel connected to, right? So when we take them away from routine, it exacerbates disease prevalence. So I think that as we entered into this world of public health, the one aspect that I noted that was really missing was, where were our faith communities, right? So a lot of them were criticized in the beginning because many were still trying to hold spaces and places of worship. Now we're online worshiping, and I think that's where we really need to check in. Not everybody can stream a service. Dr. Patel talked about the streaming and competencies related to internet access, but how can we get a word to someone who needs to be uplifted, even if it's the deacon calling or other church members? We really need to ingratiate everybody into a sense of communal orientation, communal living, and that's where spirit meets empathy and heart and human connection.
I'm just going to take a minute to talk about one program that we really started for people who did not have any family members to call in, was Adopt a Senior program. So there are people who did not have any family members. So we put it in a local newspaper, and every one of our seniors in long-term care who did not have a loved one got adopted.
I love that.
So all they had to do was call in, check in, and after the COVID is done, their commitment is 1 hour a week to go in, to have a conversation with them. If they want to straighten up their room, they can do that. They don't have to have any financial commitment. it's 1 hour a week through telephone or personally going in, whatever, after COVID is done. Right now, it's just telephone contact. And every one of our senior got adopted.
Oh, that's fantastic. I'd love to follow up with you offline about a number of things that both of you have mentioned, but especially about the adopting a senior. I have two closing thoughts before I just want to also briefly invite you all to closing thoughts and then hand it over to Brandon. So Brandon, just bear with me for about 5 more minutes. Number one, you both were talking about the pros as well as the challenges of telehealth. And I also want to introduce briefly augmented intelligence. What we're seeing in terms of social isolationism in elders in places like Japan, they're doing incredible things to be of service to elder populations, many of them who no longer have family with them, or their family, as in their children, have moved to larger cities, and so they're still in rural areas, and their care providers have given them robots to help with everyday living and remote friends or remote bots to help them cope with being isolated. So that's one thing. The other thing I do want to just honor and mention is for those who are maybe of different religious backgrounds. My family is mixed religiosity. We're Christian and Muslim, and Ramadan has just ended. And I was very sensitive, especially to some of my siblings and my sibling and other family members who have celebrated Ramadan within the closure of their home, whereas usually it's such a large and communal effort. And we certainly want to be very creative moving forward about our gatherings and ensuring that spirit is not lost in that. So those were just my 2 cents. I do want to invite just brief closing remarks from Dr. Patel and also from Courtney Lang before I hand it over to Brandon.
And I think there are ways you can celebrate. And we had Mother's Day celebration. The way we did it is my mother-in-law lives in town. And because we could not get together, we had a Zoom meeting, but I cooked some of her favorite things and delivered it to my sister-in-law's home where she stays, you know. So if we can't get together because we go out and work and we didn't want to expose her to something. So, but you can do other things that you know you can do to celebrate something. So we have to figure out ways of honoring somebody and celebrating still. So
being of service to others is a form of prayer in its universal. So it doesn't matter what tradition you represent or worship, being of service is the ultimate prayer.
So we have to get creative.
Have to get creative. Being of service is the ultimate prayer. Dr. Amita Patel, Ms. Courtney Lang, thank you both so much for your openness and for your words of strength and empowerment and information. We appreciate you today and hope that you'll stay in touch with NMQF. Brandon, I'll hand it over to you.
I just want to say thank you as well. Like I do have elderly parents as well, and so just trying to look after them being here in DC and them being in the hotspot of New Orleans. It's always a little disconcerting, but we do our best to take care of them anyway and support them any way we can. And I think the last piece of advice I would give everyone is just to remember to call your loved ones. So, and with that, I look forward to seeing you all again next week. Thanks again, Mia. Courtney Lang and Dr. Amita Patel, appreciate your words and your thoughts, and look forward to seeing you again soon.
Thank you.
Have a good Memorial Day weekend.
Yes, absolutely. Thank you.
Thank you.
Thank you.
Have a good day and be safe.
Be safe. Absolutely.